Welcome to the iDryNeedle to the Point podcast. Today we talk pelvic health and how it pertains to all patients with DN faculty and specialist Kelly Sammis. Welcome back, folks. This is iDryNeedle to the Point. If you haven't joined us before, I'm your host, Paul Kaloran, and we're going to talk dry needling. This is actually our 15th guest. If we go from, I guess, if you want to call 2020 season 1, we're in season 2. So we've had a week break, but we're going to keep bringing a rock star list of dry needling clinicians, specialized clinicians, and just topic experts. And today, we're very happy to have on Kelly Sammis, who is a PT, DPT. She has her OCS. She is a lead dry needling faculty, previously Kineticore, now EIM. She helped develop the pelvic dry needling content for some of those courses. She's done research. She's spoken nationally at conferences on some of the topics we'll touch on today, but she lives squarely, firmly in the realm of pelvic health, women's health, pelvic floor dysfunction, neuromodulation. So we'll touch on what she's doing with all of that and where her research is taking her. But really, I'm trying to make this as applicable to the masses as possible. If you are like me, sitting out there saying, nope, not a pelvic floor therapist, you do need to know its purpose, its function, how it contributes to pain and stability. And honestly, when there are patients, athlete scenarios you can improve, and when you need a specialist like Kelly to step in. So Kelly, welcome to the show. Did I miss anything?
No.
Audience?
Thanks for having me.
Of course.
That was a great intro. All the things.
So we start kind of the introduction. The first question for most of our guests is kind of, what was your dry needling exposure story? Like, when were you exposed to dry needling? What was it like? What part of your career were you in?
I was actually a new grad. So I was initially exposed about 10 years ago when I took my first course, which was mandated by the clinic that I was working for at the time in Colorado. I was not terribly fond of needles. And I actually remember during my first and even into my second course, I would always have to have my hoodie on and I would pull the hood over my face while my partner was practicing and just do it, get it over with, get what you need and practice what you need to. And it's a total pivot actually to where I am today, because now integrating dry needling is how I prefer to be treated. Like if I ever have any dysfunction that needs to be addressed. And then obviously I've been teaching it. So I ended up in the teaching realm pretty quickly, about a year after I finished the level 2 course, and have now been teaching with Kineticore Evidence in Motion for about 7 years.
Earmuffs, they're very effective for lots of things.
Very effective.
Yeah, that's funny though. Obviously, if you've taken a needling course, or maybe the way Kelly explained her experience mirrors how you approached it, but there's a big spectrum on how people first tolerate or respond to needling. Yeah, I just sweat a lot is kind of my response, but
I did have a sympathetic response on the level 2 course for the abdominal wall, which is probably quite loaded because I had this underlying pelvic floor dysfunction. So it revealed a lot too. It really helped to peel back some layers of dysfunction that I was dealing with as a clinician.
Similar question, but yeah, you are highly specialized going into research, presenting, teaching, but also in your practice, the pelvic health, pelvic floor dysfunction. So as that new grad, what drew you to that clientele, to that specialty?
Well, getting into pelvic health and into that realm was actually really personal for me. So I had pelvic pain that started affecting me more and more. And I did, the typical healthcare provider move where I wasn't going to go see anybody. And instead, I signed up for my first course in an effort to self-diagnose and figure out what was going on without going to see a specialist. So total healthcare provider move. But what started as a journey of more so like self-discovery, it really led me into what my passion was. And so I suppose it all worked out, but realistically, it wasn't something that was on my radar. It wasn't something that I graduated and I was like, you know what, I really want to get into the pelvic health realm. It was something that I actually initially said, yeah, that's not me. I'm not going to do that ever. And then I ended up with pelvic pain and went on this little journey that led me to where I am today, which is really, into pelvic health, and more of the sports performance dysfunction that you see come along with pelvic health dysfunction.
Excellent. It was a calling.
It was a calling.
Sounds like. And I think resonates with a lot of clinicians. I mean, I guess similar for me. Low back pain in high school is what got me into the clinic. And I guess when you're considering the medical side, more pharmaceutical versus I was more intrigued by the rehab potential, the body's resilience to rehab itself with physical therapy, just not pelvic.
Lucky you.
So I feel like this might be a naive statement, but I feel like you and I took our first dry needling training in the same time, around 2011, 2012. And back at that time, again, this might be naive to say, it seemed like there was not much dry needling being used in pelvic populations or for actual pelvic floor musculature. And actually, that's not even just pelvic. I'm trying to think back to that first course I took in 2011. A lot of the contraindications and like we would never use needling for spasticity or with lymphedema populations. And here we sit a decade later, and those are almost specialties. So maybe it's naive to say, but like if we're saying just dry needling for pelvic floor, what's kind of been the journey to becoming more mainstream? Because I feel like it is more mainstream today.
Yeah, you're absolutely right. I think when we first were trained a decade ago, there wasn't a lot of traction with dry needling really outside of the orthopedic realm. So definitely not in the pelvic health realm. And truthfully, it's still really it's in its infancy because there's a lack of research and then a lack of education and subsequently just a lack of utilization with the pelvic health community. And that's why it's still not terribly mainstream in the pelvic world. But I think that what we've evolved into understanding is that pelvic health dysfunction is simply a mix of ortho and neuro. And as an orthopedic trained therapist, if you're not addressing the nervous system, you're missing something. And I would go even a step further to say, as an orthopedic therapist, if you don't have a good understanding of the pelvis and the pelvic floor, you're missing something. And so I think that we've seen that we used to put ourselves on these islands, and those islands really shouldn't exist in the world of rehabilitation. We really should be blending and understanding the holistic system because we know that our body functions, honestly, like any other ecosystem. And so it's this complex network of all the systems in an effort that they have to all work optimally together to yield optimal function. And so if our movement is not optimal or not sustainable, we have to be able to identify where in that ecosystem there's a breakdown. And for me, I see a lot of clients who have traditionally failed, orthopedic based therapy, if you want to put it on its own island. And that's because there was a lack of education or understanding surrounding the pelvis and the neuroanatomy that connects it all. And so I do think that while we're still not seeing a ton of research specific to the pelvis, it's coming. And that's really what our effort is going to be here in the next couple of years, is to start integrating this more and to help the rest of the community understand the importance of the pelvis and how it really relates to the rest of how we function.
I completely agree. Even not just containing it to the pelvis and the pelvic floor, but if you don't appreciate the neurologic mechanisms, the neuromuscular, it's a word we say so often, but half of that means it's a nervous system phenomenon, that it's not just myofascial, musculoskeletal, it's neuromyofascial, neuromusculoskeletal. And that is a perfect segue into my next question. I know you have spoken on, and it's where your research is going. First of all, this word neuromodulation, some people may have heard it, some people may not have. So what is neuromodulation? And then specifically, how do you use this neuromodulation technique or term with your clientele?
Yeah. So neuromodulation in itself, it's a pretty, I mean, general definition, which is it's just modification or alteration of the nervous system, meaning inhibition, stimulation, regulation, therapeutic alteration of the activity within our central, peripheral, or autonomic nervous system. We're just modifying it or altering it in a way that creates change. And there are a lot of ways that we do this as healthcare providers outside of even the physical therapy realm. So we have to think about, for us, we typically use things like electric stimulation, modalities, movement, neuroscience education, hot, cold, all of that modulates the nervous system. On the MD side, you've got things like procedures, pharmaceuticals, more of your chemical agents, all with the objective of pain mitigation, inflammatory mediation, nourishment to the tissue, and then restoring function. And so the way that we are utilizing neuromodulation and what you're going to see in the research that's coming is we want to modulate or alter the nervous system via stimulation, via electric stimulation. And most traditional therapists will think of, your TENS, right? And most of your patients can relate to that. Like, oh yeah, I've done that before. Like I've done the TENS and like similar theory, except our electrode now is a little bit different. So the way that we're going to be looking at neuromodulation is via dry needling. So utilizing a tissue specific indwelling needle electrode in an effort to be more specific in our delivery of electric stimulation and to create change, hopefully, more efficiently, more effectively. And if you really break it down to just trying to understand the mechanisms behind dry needling and why this suddenly becomes such a powerful technique that we can use, we know that we can create change in regards to the biomechanical piece. And that's where most of us have a good understanding. Like if you look at the trigger point model or the radiculopathic model. So then you've got that biomechanical piece and the neurological piece that we have a pretty basic understanding of. But when you start to dive deeper, you see that we've got the ability to see a vascular mechanism behind it. You've got a biochemical mechanism behind it. And if we know anything about nerves, and we've heard this time and time again, when you're talking about the nervous system, they like space, they like blood flow, they like movement. And we can actually provide all of that via neuromodulation utilizing dry needling. And what we've seen in the world of pelvic health, and so a lot of my clientele, especially in the sports realm, so I treat a lot of triathlete cyclists who are dealing with pudendal neuralgia. So with pudendal neuralgia, you see their options for treatment that they are provided are very heavy pharmaceutical, very heavy procedural, maybe all the way to a surgical procedure. Meanwhile, we're sitting over here going, wow, we have this really conservative treatment approach that is incredibly powerful, that can help to restore function, that can help to mitigate pain, that can help to get you back into the saddle without, I would call some of those other procedures aggressive procedures. And yet we're not using it. And so realistically, with neuromodulation, the field is evolving as it should. But we're seeing a lot of advancement in regards to how we can utilize it as rehab professionals. And so that's where we're going with our research. That's why we're going there, is because we know that we can influence the tissue in a way that we can tap into all of these different mechanisms, and we can create change quite effectively and efficiently for our clients.
I love it. Just nodding along the whole time. Because, yeah, I mean, if you break down the word, most of you, even if you had never heard it, probably understood neuromodulation, what the goal is. Sometimes it's confused, even in research, that you need a direct electrical, like a needle, an indwelling needle electrical stim to a peripheral nerve. Those techniques do exist. That's out there. But when we just say neuromodulation, and yeah, Kelly is entering into some research with it. It's out there in research, meaning if you're searching through and you see PNT, that can be peripheral neuromodulation therapy or percutaneous neuromodulation therapy. Sometimes they're stimulating a nerve directly, a peripheral nerve directly. Sometimes they're stimming muscular targets, which is what most of us do in the clinic. You can neuromodulate glutes. You can improve contractile thickness, EMG latency. You can decrease pain pressure thresholds. You can improve mechanosensitivity. You can improve neural tension. All of those are signs that we modulated the nervous system. So really, it's a fancy word. It's one that I don't use in the clinic, but you could. And if you really want to add that central nervous system punch or emphasize that it is a nervous system response, if you're using needling, and especially using needling in e-stim, I do think e-stim has the ability to just speak the nervous system's language more effectively. Like you add electricity, you can generate responses, whether it's sensory or motor. That's neuromodulation. Maybe I should just start saying I'm going to neuromodulate your glute medius.
I think it's good. I love it. Well, and it's interesting because you have to think most clinicians don't realize that neuromodulation, I mean, you even have to consider your pain science education in that realm. You could be hands-free from a patient and create change and modulate what's going on in their autonomic nervous system. Like, it doesn't necessarily mean that you have to be using dry needling. However, if we think best effort, and I think best effort for my clients in the spectrum of treatments of conservative to aggressive, best effort, that should be one of the first lines of defense for our patients. It really should, but there isn't enough literature out there for the medical community, so more the MD side, to understand that. And so we have to think about too how our patients go through this process and how they kind of who they see first. And a lot of times they're offered more of the pharmaceutical realm or, your procedural pieces to the puzzle. So I'm hopeful that with this new research that we can start to see the PT side, the rehab professional side, be more of that first line of defense for patients.
Totally. And I think that's probably a podcast for another day. I mean, we kind of live in this very previously benign sounds bad, but like this very risk adverse profession where now we're using needles. It's invasive. It has higher risk profile than something else than what we were doing previously. And even inside our own profession, that starts to take on the context of dangerous or aggressive. But when you take it in the larger context of what are the other treatment options out there, especially pelvic pain, it's pharmaceutical, it's surgical, it's injectable.
Injection-based, heavy.
So you put dry needling in the list of treatment options and you want to deduce which one is the most aggressive or the most invasive or has the highest risk, it pretty quickly becomes one of the safest, one of the best.
Yeah, it's not us. Options. Yeah, it's not us. We're more on that conservative side for sure.
Okay, well, I want to, you're very pelvic. I know you live in the pelvis, basically. Every Instagram post I see from you, there's a pelvis model in it.
Even the baby holds it, I tell you.
But I want to put some of your recommendations into someone who would say they're not a pelvic therapist, or they're general orthopedic, or maybe they're more like me. They see athletes and you start to think like, oh, I'm not a pelvic health specialist. I am an orthopedic specialist. So first of all, there are courses. Kelly teaches, she's developed courses where you can needle the musculature of the pelvic floor. And for certain patients, diagnoses and dysfunction, that's very necessary. But I'll ask you, Kelly, what are some very common treatment targets you treat that most of the other clinicians out there on their level 1, level 2, that they know how to needle, but directly impact the pelvic floor, its function, decreasing pain? Give us a short list of muscles that most clinicians actually do know how to needle that you're doing in your pelvic specialized realm.
So from a needling standpoint, you have to consider the neuro piece behind it. So spinal segments are huge. I'm typically doing myotomal circuits with a majority of my clients. And so if you've been trained in dry needling and have gone through, a level 1, level 2 course where you have access to the entire spine, thoracolumbar region, huge innervation to the pelvis. mean, you've got to think where the ilioinguinal, iliohypogastric, genitofemoral nerves come off of. That's all TL junction. It's also the innervation to our organ systems, bladder, bowel, uterine. And so spinal segments are huge. You come down south now and you've got to think sacrum. So sacral segments, S2, 3, 4, that's where the pudendal nerve comes off of. That's our powerhouse nerve to the pelvic floor. And so spinal segments are massive in regards to how you can influence how the pelvic floor functions. Past that, you've got to look at everything that attaches to the pelvis. I mean, we're talking a huge number of anatomical structures at this point. So if we break it down to just the very obvious and talk more like core canister, so we've got abdominal wall that plays a big impact. So if we're unable to get into our diaphragm, if we're unable to tap into a proper breath, our pelvic floor will tend to be more on that hypertonic side. If the reason why we can't get into the diaphragm is because of all the superficial restriction throughout the abdominal wall or the trunk itself, we need to be addressing that. So you're thinking more of like your anterior sling, your posterior sling, your lats coming down to the thoracolumbar fascia, how that interacts with then it wrapping forward into the oblique line, into the rectus abdominis. Like you've got to be addressing that stuff. On the same token, if you've got dysfunction in the core canister, thinking more of a coordination issue, like you don't have good control of intra-abdominal pressure. And now we're going to kind of bridge into more of that sports realm. I see this a ton with our athletes. They have compensatory patterns like crazy. And you're talking high performing athletes at this point that have some of the poorest intra-abdominal pressure control that I've ever seen. So it's no wonder why you see it trickle down into dysfunction in the pelvic floor, because that system is incredibly interrelated. So if you're an oblique gripper or you grip through the rectus muscles and you can't tap in or facilitate properly into the transverse ab, the pelvic floor has a Peace Corps gene. It's like, don't worry, I got you. I'll help you out. And it's the first thing to allow you to continue your task. And that's why it tends to err on the side of hypertonic with our athletes. That doesn't mean that you have to stop doing what you're doing by any means. It just means that you need to learn how to regulate your intra-abdominal pressure and coordinate your core appropriately. And so I think a lot of people think pelvic therapists hyper-focus, like it's all intravaginal, intrarectal work, and that could not be further from the truth. I rarely integrate that into my practice, rarely. And so it is one of those things where you can have such an influence on how the pelvic floor functions as a traditional orthopedic therapist by simply understanding the connection and how it works alongside the diaphragm, the rest of the core canister in regards to abdominal wall, and then wrapping back into the spine and the segments.
And that's everything. I mean, if you're saying that the pelvic floor, well, it is anatomically, it's the bottom of the cylinder. It's part of our core. So even if we just say intra-abdominal pressure and how important that is, again, I'll put it in my context of athletes, of CrossFitters, everything from intra-abdominal pressure bracing for a heavy lift, 1 to 3 rep max, deadlift, squat, to more of the body weight, but repetitive, like a double under. I mean, you need quick activation. You need that bracing stability of the core, which we all know, we all agree when we say the core, like, yeah, we need good core stability. But then we fail to realize the cylinder has a top and a bottom. And probably because we don't know as much about it. I mean, me personally, I would say. Of course.
We like to shy away from the things that aren't comfortable, right?
Right.
But honestly, it's just educating yourself of how it works, like what's the big picture, the holistic function, the ecosystem of the core. And if you can understand that piece, you're going to be you're a better clinician for it.
That is my next question. And it's probably our last question. Sorry, I kind of stopped saying we keep it at 15 minutes because I couldn't do it. Literally couldn't do it. But we still try and keep it succinct, to the point.
Yes.
So yeah, again, if we're saying there's these general clinicians, and again, I'll just say myself, earlier in my career, I do think I am more educated now, but I shied away from discussing the function and importance of the pelvic floor because insecurity. I honestly didn't know how to cue it. I didn't know how to train it. I didn't know what volume cue task to give my patient. So if I start giving them this emphasis. So the last question, or I guess two things, kind of what's your pitch right here to our audience that are like me? They really don't know much about the pelvic floor aside from where it lives. What's your pitch? Like, how much education should just the general provider have on the pelvic floor? And I'll go a step further of, I used to see endurance athletes, Ironmen and women, and they're cyclists, which means pelvic pain is common. And my little spiel was, I'm not a pelvic specialist. I can treat, like you've never had dry needling, I can treat some of these structures that I know influence the pelvic floor. But honestly, my spiel was, if we're not seeing any improvement in a couple visits, here's a referral. So the question is, what's your pitch? Like, how much education should every clinician have on the pelvic floor? But also, when should, let's say, that non-pelvic clinician consider referring out to a specialist like yourself?
So to the point, you have to acknowledge that the pelvis is literally the crossroads of human function. It's our intersection. It's our intersection of the axial and appendicular skeleton. And in relation to how that impacts human function, it is huge. And so from an education standpoint, we have to just lend towards function, because does everybody have to go through intensive pelvic floor education? No, but we do need to understand how it impacts function. The pelvis is responsible for a lot. It has a role in postural aptitude, load transfer, force generation, and no doubt that can get complex really quick, but you have to understand the basic physiology behind that. And then how we as non-internal therapists can influence the system. So if you're unfamiliar with the pelvis, its roles and those three things, I mean, think about it. Posture, load transfer, force generation, is that not something that we are talking about with every client that walks through the door? And so if you're ignoring the pelvis and its role in that, you're missing something. So find a course. It doesn't have to be an internal based course. Just find somebody who's well versed in it, that has even an online course to walk you through it. And then when it comes to referring out, honestly, you just have to, if you stop creating change with your client, if you have done your due diligence of evaluation, assessment, attempting to identify primary driver, and you're throwing the treatment options that you have at that client, and you stop creating change, you have to be okay with going, you know what? I think I'm missing something. I think it's time that you see somebody who's a little bit better versed in the pelvis. And that's when I would say you refer out, and whether that's to a colleague, to a pelvic health specialist, to whatever. If you aren't creating change with your client, it's time to think about a referral.
I like that. You make it sound so obvious, though. I was looking for like that highly strategic algorithm of when to refer out. But
if your client is peeing on the platform during a lift, consider a pelvic health referral.
So first of all, there's our T-shirt coming soon. Just have a pelvis on it, but the pelvic floor, the crossroads of human function. Write that one down.
Write that one down.
And I'd actually say education-wise that, yeah, there's great stuff. EIM has all sorts of online resources, MedBridge. Honestly, if you're kind of skeptical, a great first place to start would be to follow someone like Kelly on Instagram. You can find her at Holistic Pelvic Health on Instagram, because she posts fun facts, anatomical nuggets, clinical pearls, and things that you can just easily digestible, like the quick and easy content of social media is a great place to start. But that is our time for today. Way over time, but yeah, I appreciate you being on, Kelly. If you're catching this recording, because we didn't actually broadcast it live, It's on YouTube. It's on our education platform. You can hear the audio on Spotify or iTunes. If you are on YouTube, I'll plug some of our other episodes we've had, because we mentioned pain science briefly, and recently Adrian Lowe of EIM, previously ISPI, was on. We talked about eStim. There's episodes where we talked exclusively about eStim. So this is the first time listening. Thanks for joining. Kelly, thanks for being on.
Thanks for having me.
And I'm sure I'll see you very soon. We are colleagues. But yeah, that's it for this week, folks. We may not be back immediately next week, but we do have a list of guests coming up. TKO DPT, TK is her name. She is both a physiotherapist, dry needling physical therapist, and a Muay Thai fighter herself. And she works squarely with the mixed martial art clientele, basically treats in a gym. And we have more coming, a long list, but I'll give you teasers as to what's coming. So you can follow Kelly at Holistic Pelvic Health. You can catch us on all the podcast platforms. And this was iDryNeedle to the point. Thanks for listening.